The focus of my program this morning will be on the management of the open interproximal space. This is a topic of great interest to both clinicians and patients alike, as is evidenced by the fact that 4 of the 6 presentations in today's session center on the lack of papilla open interproximal space. It historically has been a very difficult dilemma in dentistry because the anterior papilla is an aesthetic element is an essential element for anterior aesthetics, yet we haven't had good solutions on how to resolve this problem. I'm going to briefly review the diagnosis and etiology of this problem, talk about traditional periodontal plastic surgical solutions, and spend the bulk of my time talking about novel new tissue engineering approaches that may allow us to manage these problems in a different way than we've done in the past. You know, the title, as Jim said, of this entire day is Rational and Predictable Periodontal Plastic Surgery. And when you think about predictable periodontal plastic surgery and you look at all of these perioaesthetic dilemmas, the only one of these that we cannot predictably manage day in and day out is the open interproximal space. And when it comes to the open interproximal space, we have unique challenges in all of these areas around implants, Pontics, and teeth, and we'll briefly look at all of these, but spend most of our time around teeth. Now, when it comes to the concerns around implants and Pontics, you can't have implants or Pontics if you don't take teeth out, and you can prevent some of these problems at the time of extraction. The most effective ways of recreating a papilla is to never lose it. And one of the things that we have to be prepared to do when we take teeth out is to be able to immediately reestablish the gingival embrasures, because what happens is if it's the gingival embrasures that maintain the shape of the papilla, and we need to be prepared as soon as we take these teeth out to be placing Pontics with appropriate extensions into the extraction socket. I usually will use a Pontic of around 2.5 millimeters that's going to support the facial free gingival margin. I want a Pontic that's going to recreate the exact gingival embrasure, and if we do that, we can then maintain very sharp free gingival margins and papillas. It's almost standard of care today that anytime we take a tooth out, that we're placing something into the extraction socket. Asella and others have shown that by doing this, you maintain bone and soft tissue height that's important for maintaining papillas. So here I have an intact extraction socket. We're just going to extract the tooth to bride the defect, and in this case place a little mineralized freeze-dried bone, a collagen membrane, and a removable provisional partial denture that's going to immediately support that free gingival margin and begin the process of creating the ovate Pontic. I've marked here with just a red pencil showing how far that it's extending into the extraction socket, and you can see how it's maintaining that facial free gingival margin and provides a very believable soft tissue to Pontic relationship. And now, regardless of whether we're going to proceed with a fixed restoration or an implant, we're already ahead of the game because we haven't lost any of our papilla. If we're talking about implants, there are some very important guidelines that we have to follow. The presence of the papilla adjacent to implants depends on the surgical and restorative phases when appropriate apicoronal and mesial distal dimensions are established, and all of these authors and others have provided those guidelines for us. You know, whether it's a tooth or an implant, it is the interproximal bone that determines the height of the papilla. And if we extract a tooth and replace it with the implant, it's the interproximal bone adjacent to the tooth, not adjacent to the implant, that maintains that height. If we place our implant in the proper three-dimensional framework, as I have here, we can create an implant-supported restoration, as you see here, with very nice sharp papilla. And in fact, you can't even tell where the restoration is. And of course, that's what our goal is in this process. One of the reasons why that last case looked so well was because it was the adjacent teeth, the biologic width on those adjacent teeth, that were supporting the papilla. David Cochran in the late 90s, in a series of papers, talked about the fact that the biologic width is different around implants than it is around teeth. And let's spend just a moment on biologic width to make sure we're all on the same page, because this will be a continuing theme throughout my presentation this morning. If we look at this diagram, we see that as a rule, our bone crest. The contour of it will follow the contour of the CEJ, as does the free gingival margin. We have a biologic width around teeth that's suprabony. We have it on an average of about 1 millimeter connective tissue attachment, about 1 millimeter junctional epithelium, about 1 millimeter of sulcus depth. And if you look at the papilla, and if your contact area is no further than around 5 millimeters from the bone, as a rule, you're going to have a full papilla here, and that papilla is going to be made up of about, on average, 3 millimeters of sulcus depth and about a 2 millimeter biologic width. If we extract one of those teeth and replace it with an implant, and in this schematic, the facial bone's been removed so that we can see what's going on interproximally, we have our biologic width on the tooth, suprabony, but around the implant, we have a subcrestal biologic width that goes from the implant platform subcrestally, and it causes bone resorption to that point. We don't have a problem with the papilla, though, because the papilla is being maintained not by the bone on the implant, but by the bone on the natural tooth. The problem, of course, is what happens when we take this tooth out, and that then becomes the real challenge, because now we have a subcrestal biologic width on both adjacent teeth, and the bone then resorbs down to that point. Now, there's lots being done, as we all know, lots of great courses at this meeting on implants, talking about changing the surface of the implants all the way to the platform. That could make a difference. Platform switching, scalloped implants, all sorts of different ways that we may be able to avoid this, but at present, there's no real good way for us to predictably avoid the fact that the bone's going to resorb. And again, guidelines are telling us that from the contact point of your restoration to the bone around adjacent implants, you can only expect a papilla, excuse me, about 3.5 millimeters above the bone. Now, if you have a patient with 2 implants in the anterior aesthetic region, this is going to be a concern, and you need to make sure you talk to your patients about the fact that you're going to have to make, at least today, you're going to have to make some compromises. You know, you need to decide, are you here for function, are you here for aesthetics? Implants, if you have a choice, may not be the best approach if you're placing 2 adjacent implants. Along with the apicoronal guidelines, there's also mesial distal guidelines that we need to pay attention to. These authors have established those, and that is that we want to make certain that we don't have our implants any closer than about 3 millimeters to each other. Again, the reason for that is because of the subcrestal biologic width. That will cause the destruction of the bone interproximally and create a more difficult situation with lack of papilla between these 2 implants. That said, if you follow all these guidelines, as I did in my case here, even with 2 anterior implants in a patient with a relatively high smile line, we can get a reasonably good aesthetic result. You know, if you're very critical, you can see that the papilla doesn't completely fill this, but, you know, not bad as long as you follow the guidelines. And you better follow the guidelines because, again, today it's extremely difficult to come in and surgically augment these areas after the fact. The reason for that is because there's far less vascularity in the connective tissue around these implants than we have around teeth. And we're going to spend the day almost talking about how difficult it is to do around teeth. Because you don't have the vascularity of the PDL and the other associated vessels, the connective tissue around these implants are poorly vascularized as compared to teeth. And it's much better to make sure that you capture and preserve these papilla rather than come back in and try to create them later. Let's talk about a moment about Pontics, because I think that's an area sometimes we forget about as it relates to papillas and open interproximal spaces. If you have more control of the papillary position when you're replacing single or multiple teeth with Pontics, that if the adjacent natural teeth have bone loss, a soft tissue ridge augmentation followed by the placement of a Pontic can achieve greater coronal height of papilla than a single tooth implant in the same situation. That, of course, is because the tallest papilla you're going to get around a natural tooth is going to be somewhere around 4.5 millimeters or so. And so if you've lost bone on that tooth, and you're going to come in and place an implant, there's no way that you're going to recapture that papilla, because the height of the papilla is going to be controlled by the bone around that natural tooth. So unless you're going to orthodontically extrude the tooth or go through all sorts of different machinations to do that, you're in trouble. Yet if you come in and you do a ridge augmentation, you can grow a greater amount of tissue. On average, you can grow up to, on average, around 6.5 millimeters in a ridge augmentation, up to 9 or 10 millimeters in some cases. So you have to make sure you're thinking about that in your armamentarium, and if you have a situation in the anterior region, I'd much rather space out my implants and have a nice Pontic in between. We can control the papilla much better because of that. Here's a situation, just a class 1 recession, where we have open interproximal spaces, a very simple connective tissue ridge augmentation, and I'm able to close in these papilla and create a very believable Pontic. Much more difficult situation here, a class 3 alveolar ridge defect. We're going to have to come in first with a connective tissue ridge augmentation to plump out the facial, and then an onlay graft here to fill out the tissue on the apicoronal dimension. But even with that large area, it took 3 surgeries, but we're able to come in and have nice papilla between these Pontics. Now, the whole reason that I will do a ridge augmentation is to create the situation for ovate Pontics. Of course, ridge lap, modified ridge lap, and an ovate, and we'll come in and we can create the ovate Pontic receptor site with whatever you like, a electrosurge, a diamond instrument, a laser. It doesn't make any difference. But what you have to be prepared to do is you have to make sure that either you or your restorative partner is going to extend the provisional restoration into your receptor site, because if you go in and you create your ovate Pontic receptor site and you don't then extend the restoration to maintain the papilla, maintain the free gingival margins, then it will collapse into it. And so that's what we were doing here. We were just adding some flowable composite to make sure and we're recapturing that, and you can see how we're able to maintain very sharp, nice papilla there. How about, can you keep these areas clean? Are they healthy? Do the papillas maintain over time? Here's a patient that we're chief complaint open interproximal spaces, so we go in, we do our ridge augmentation. We've not yet done the ovate Pontic receptor site yet, but this is just what the Pontic is doing. Now I've come in with electrosurge, created the ovate Pontic receptor site, and note that we don't just go in and make a little circle. See how this tooth is prepared? See the shape of it? I mimic that shape in my ovate Pontic receptor site. The bridge is seated. But what I want to show you is 7 months later, we removed the provisionally seated bridge and look at the health of the tissue here. Obviously, this lady is flossing underneath this Pontic. She's able to keep the tissue nice and healthy. And here's, you can see how the Pontic is maintaining out at around 5 years. We had a little bit of recession that I covered with a graft so that we didn't have to have that bridge replaced at about 5.5 years. Another patient that was in an automobile accident. She was a dental hygienist and just completely lost all of her tissue in the maxillary anterior region. Through 3 different surgeries, I plumped all this out so that now we've got a nice ridge contour, but most importantly, it's allowed me to build this interproximal papilla. And of course, that's where you're going to make or break this particular case. Also creates nice free gingival margins that we can create very believable soft tissue to Pontic relationships. Another patient with a high smile line, and we have an endodontically failing tooth. And in this case, believe it or not, I actually orthodontically extracted this tooth because I knew we were going to have a problem. I knew it was a highly aesthetic situation. And even with the orthodontic extraction, I end up with this monster defect here. Now, you know, I'm starting to sweat a little bit because how predictable is it to regenerate the tissue here on the mesial aspect of this lateral incisor? And the case will key on us doing that. So I go in, I do a little inlay-onlay type graft, And fortunate for me and her, we were able to regenerate a considerable amount of tissue. I mean, you're talking, I mentioned a minute ago that your range is going to be maybe up to 10 millimeters with a graft like this. And I think, we achieved right about that. So now we have a nice broad ridge, we have a nice papilla, and we're able to go in and place our restoration. Now this happens to be an implant. But when I do these things, I like to go in and get my soft tissue contours first, then go back and do my implants, any bone grafting at that time, because I feel that I have more control of the soft tissue contours before I place that implant. I also did a tissue replacement, graft to eliminate the mucogingival, the amalgam tattoo, implants in place, and a fairly nice result in a relatively high smile line. Another real workhorse in our office is a graft that I published on in the middle of the 1990s, and it's a graft that allows us to go in and generate a lot of tissue around Pontic in order to create papillas. I knew immediately that this was going to be a fantastic case because I didn't get my first picture. And as you know, anytime you don't get your first picture, it's going to be a blockbuster of a case. So what you're looking at here is this is a provisional restoration. When the patient initially came to me, she had a fixed restoration all the way subgingivally here and of course in the Pontic, and I asked that that restoration be removed and a provisional restoration be constructed, leaving the margins at relatively ideal tooth length and contours, and I'll do my best to bring the tissue down to that point. So I use this as a surgical guide. I place my pencil mark on the root surface so that I know when I take the bridge off, that's where we have to root plane scale. Take a nice piece of connected tissue. I remove the restorative margin. You'll see it on another case in a moment. I place the connected tissue over the previously restored root surface, place an interpositional graft in between, and this interpositional graft is going to be a key here because it's going to support this connected tissue so it doesn't drop into the alveolar ridge defect, but most importantly, it's going to allow us to build in the tissue adjacent to the teeth because that's going to be the most challenging part of this. We suture, place our restoration, and a few months later you can see we're probing and have minimal probing depth. And look at the volume of tissue that we're able to regenerate here. Again, you're looking at 7, 8, 9 millimeters of tissue there, and the final result. Look at, I'll just show you a number of cases with that very same technique. You can see these teeth are way too long here, open interproximal spaces. So we go in, we use that same technique, we resolve the alveolar ridge defect, but we also fill in these open interproximal spaces by using that interpositional graft. Similar case where this patient was in an automobile accident and they masked the fact that there was no papilla here with making these teeth in a kind of an unusual shape. Use that type of interpositional graft and we're able to go in and create the form of papilla. Same technique here. This bridge needs to be redone. You're either going to continue to chase this that way if you're going to just continue to make new bridges, but we take this bridge off, have a nice provisional made, leave your margins at ideal tooth length. I'll come in, remove the restorative margins, graft over it. And again, I don't think you could tell where the Pontic is here if you weren't looking at the sequence. Another patient chief complaint, open interproximal space, but again you can see we have all different tooth lengths. If you look laterally, you see we have a large ridge defect here. We're going to do a tooth length analysis. We remove the bridge, create a provisional at appropriate tooth lengths and contours, and I'll graft down to that. So here is the bridge on after I flap it. This is the butt joint margin from the restoration. We're going to, I mark also where the margin of the bridge is. We take that off, and so from here all the way to the alveolar bone, we're going to do a little Texas-style root plane and scaling with a high-speed finishing burr. I'm going to eliminate that butt joint margin. That then allows me to come in and graft over that, placing our interpositional graft interproximally, connective tissue over that. This is how it looks at the end of the first surgery. This is how it looks about a month later. So we've covered the root surface here, but we've not yet resolved the open interproximal space. You can see how just the Pontic is beginning to create a nice ovate-Pontic relationship. We're going to take some of the tissue that we were successful in growing facially as we covered this, and we'll move it in the form of a pedicle to recreate our papilla here. I'll recontour this as I place the restoration on. So this is the beginning of surgery 2, the end of surgery 2, and this is about 45 days later. We now have a nice full papilla here, and we're beginning the process of creating a nice ovate-Pontic receptor site. We now have appropriate tooth links and a believable soft tissue to Pontic relationship. We're to the point now to do a little gingival recontouring, and she'll be ready for restorations. Well, let's finish the program talking about teeth, because this is where the real challenge is with open interproximal spaces. And there's 3 reasons that you can have an open interproximal space when it comes to teeth. You can have diverging roots and diastemas. You can have anatomical abnormal clinical crown shapes, and hard or soft tissue loss. Fortunately for us and for the patients, the most common reason for open interproximal spaces around teeth are the first 2 reasons. If you have a diverging roots or diastema, if you look on the radiograph and the teeth look like, the roots look like this, you say hallelujah, because all you have to do is just align the roots, and of course the open interproximal space closes. Or in this case, if you have a diastema where they've closed it with a little restorative material, just remove that, move these teeth together, and you compress the papilla. Abnormal clinical crown shape also affects how the papilla is. Kirch and Koch looked at just on average, you should, for a nice aesthetic result, you should have about a 50-50 relationship between the length of the contact area and the papilla. So when you look at these anterior teeth, you should be seeing about half tooth and about half papilla. And we know that it's the contact area and shape of the tooth that controls this. Ideally, you want a contact area in the coronal or apical, in the coronal 1/3, not a contact point at the incisal edge. And if you look and you have a contact point, then you can go in, reshape that, and do a little orthodontic movement and close it and resolve that. Because it is tooth form and contact that dictate the shape of the papilla. Now sometimes you'll have a combination of these issues that you have to manage. This is a patient that was interested in some aesthetic improvement. She was sent to someplace else and had a frenectomy that was botched, and not only did they remove the frenectomy, they removed the papilla, caused all sorts of recession on this. So I go in, not really to grow a papilla, but just to plump this out, to do my best to cover some of that root surface, and now we begin to do a tooth length and width analysis, move these teeth to where they need to be, and come in and finish it off restoratively. So oftentimes these things take a team effort. If you look and you don't have diverging roots or diastemas, and you don't have abnormal clinical crown shapes, then the problem probably relates to a hard or soft tissue loss. And this is much more difficult because this is the area that we have yet to find predictable solutions to. That's why so much energy is being spent on this. Now, a lot of papers out there talking about papilla preservation type flaps. And while these are important, these really are not what maintains the papilla. I mean, this is one of my cases where I've come in, I've created a straight line incision on the lingual, I've moved all the papilla out with the facial flaps. You can see all the papillas here. You know, obviously don't want your assistant with their suction, not the time for that, but you're able to maintain the papilla. But you know what, I could go in and cut those papilla off. They're going to come back because it's not my flap design that's maintaining those papilla, it's the bone that's maintaining those papilla. And we have a number of studies that show us that. Vandervelde, one of the earliest in '82, went in and did interproximal denudation and looked at 3 years later, and what he found was that on average the papilla grew back to about 4.5 millimeters with about a 2 millimeter sulcus depth. Dennis Tarnow found the same thing in his off-sided paper, where if you have a contact point, a contact area that's no further than 5 millimeters from the alveolar crest, 98% of the time you had a full papilla. So this 4.5, 5 millimeters continues to come to the forefront as far as what kind of papilla can we expect maximum between teeth. So here's one of my cases. This is after some fairly significant crown lengthening. This is just a few months later. I can't read it 3 months later, after the restorations have been placed. I want you to notice the open interproximal spaces here, the lack of the papillas. My patient may be asking me, hey doc, how about these? You know, okay, how about those? Can we sleep at night? Sure we can, because I know for a fact that these contact areas are less than 5 millimeters to the bone. We make certain that we look at that. That should be part of your laboratory slip as you're going to the lab to tell them exactly where you want these contact points, because you can see how these papillas have filled in, and it only takes around 6 months or so for that to happen. And there's this, again, not rocket science, just follow the guidelines and you'll know what you can expect. Now, let's spend a moment again on biologic width, because biologic width also affects papillas. And I don't know about you guys, but biologic width is something that I struggled with as a clinician a little bit. When I was in dental school in the early 70s, I remember sitting down to do my very first anterior crown. I was a junior. They didn't trust you to do that until you were a junior. And I sat down with a board-certified crown and bridge prosthodontist, and she said, okay, Mike, let's put that crown margin right on the bone to make sure that we don't, show any of the restoration. Well, we didn't know any better at that time, although if you look, this was published in '61, and I'm talking about '74, but it hadn't translated into clinical practice. And then later, as we all began to learn about biologic width, that we need, some space for the attachment apparatus to attach, about 1 millimeter connective tissue, millimeter of epithelium in your sulcus, and that if we use bone as our constant and we measure from the bone and you place your margin 2.5 millimeters, that you're never going to infringe on the biologic width. Well, I can tell you as a clinician that didn't make sense to me. I can tell you that I oftentimes would see crowns that I knew that the margin was right on the bone, yet there was no inflammation. I also would see crowns that I knew were at least 2.5 millimeters from the bone. And I went through a differential diagnosis, and I knew there were no other reasons for this inflammation, yet they were chronically inflamed. It just didn't make sense to me. It started to make better sense as I looked at Vasik's article here, where he basically just repeated Gargiulo's article, his study. And what did he find? He found about the same thing, about 1 millimeter connective tissue, millimeter of epithelium. But what you to look at is the range here. The range on epithelium, 0.3 to 3. Connective tissue, 0.3 to almost 2. So, it's this patient right here that has that crown on the bone that didn't cause a problem, because this patient has a 0.6 millimeter biologic width. I'll take a practice full of those folks, because it's this one that reaches out and gets you that has a 5 millimeter biologic width. This is the patient that you place your crown margin 2.5 millimeters from the bone because you're doing what you think you're supposed to be doing, and you're in the middle of the connective tissue attachment on this patient. So the bottom line is a biologic width is a constant, but it can vary greatly between patients. And in our practice, we calculate the patient's individual biologic width. After they're anesthetized, I'm going to sound from the free gingival margin to the bone, subtract the sulcus depth. That's going to give us our individual biologic width. That's important in papillas because variations in the biologic width also affect papillary height. Again, if we have our typical 5 millimeter papilla, on average, it's about a 3 millimeter sulcus depth, about a 2 millimeter biologic width. Well, you can have variations. You might have a 7 millimeter papilla here. If you have a 5 millimeter sulcus depth and a 2 millimeter biologic width, this may not be a very stable situation. Yet you can have that same 7 millimeter papilla, but if it has a 4 millimeter biologic width, it's going to be much more stable. Periodontal biotype also influences papillary form. Obviously, you can have your highly scalloped or your thick and flat. Some suggest that the thick and flat's more stable, but as far as papillas, that's not really perhaps the most aesthetic, so that's a problem. Other papers have talked about how we can go in and rebuild these papillas surgically. And unless I've missed somebody, I believe this is the world's literature on surgical rebuilding of papillas. And I've learned much from these master clinicians. But all of these papers have one thing in common. All of them are single case reports or small case series that tell us nothing about predictability or long-term stability. Now, can you rebuild papilla surgically? Sure you can. Patient of mine, open interproximal space. If you need a papilla, why don't you take a papilla? So, you know, I'm smart. Let's go. I'm going to take this little papilla from the lingual aspect between these bicuspids. There it is. Let's create a little pouch here. Place a papilla there. This is my before picture? No, this is my before picture. You know, if anything, he looks worse after that augmentation than he did before. I didn't grow it where I wanted it, but boy, I grew a nice wart of tissue right out there, though. So, you know, let's make lemonade out of lemons and let's move this tissue here. But could I do this if these teeth were not prepared? No. So I'll take that in the form of a pedicle graft, I'll move it interproximally, and we create a nice papillary form. How about this patient? This is another dental hygienist. She went to somebody and they did connective tissue grafts that they all failed. Hard to believe in today's world that, you know, connective tissue grafts are so predictable, but not only did she lose all this tissue, but more devastating to her, she lost all of the interproximal papillas here. So we're going to go in, we do connective tissue grafts first, and we achieve exactly what we thought we would achieve, and that is we're going to graft just down to the height of the contour of the interproximal tissue. But that's not enough. Now she wants us to see what else we can do. So we're talking about procedures here that have high value to the patient, but also high risk. The more you get into this kind of stuff, if this fails, you only thought she looked bad. So we're going to go in, we make a full thickness incision in the vestibule, basically deglove the maxilla around these teeth. We're going to move it down. We're going to undermine all the way to the lingual. I place a little bone and a little piece of connective tissue over the bone. We'll suture it, and after restoration, we get a reasonable result. But again, these patients are willing to go through these procedures because it's so important to them that they recapture the papilla. How about this patient? This patient was sent to a periodontist to have a regenerative procedure between these central incisors, and it was done with a membrane, and frankly did a pretty good job of regenerating the bone, but lost the papilla in the process. Now, high smile line, what would you do if this were you? I know if it were me, I would do anything to recapture this papilla. So the first thing I do is I go in, I'm not trying to put anything in the interproximal region, I'm just bulking this tissue out to give me something to work with. So here is our graft in place, and here we have it 30 days, so we've got some tissue that we can work with here. I actually recontour these teeth to give me a little more space interproximally. I place a little interpositional graft, a little connective tissue from the tuberosity. I'm going to coronally advance then in the form of a pedicle graft over that, and this is at the end of that surgery. And this is how the patient comes the next week. Now, this is a very important little window of opportunity. You can see that we've grown a little tissue here, but if I send this patient home, that's going to round off. We're going to lose it because remember, contact point and gingival embrasures help maintain this. So that day, I have to add a little flowable composite to make sure that I have my provisionals lightly touching that. And if I do that, this is what it looks like at 30 days. You know, I'm having, as a periodontist, to relearn some restorative things. I mean, I talk about flowable composite, what's that? So, is it possible? Yeah. You know, we were able to regenerate a tremendous amount of tissue here, and with that high smile line, very important. And I have, you know, detailed surgical slides on all of these and others, and I could write this up. But you know what? I don't know I could do that again, much less show you how to do that again. But we have to address something to be able to do this more predictably because this is such a high-value procedure. And I believe biosurgery will allow us to do that in the future. Biosurgery is surgery with an active component. I'm convinced that in the future, you and I will not be doing any surgeries that are passive. Everything will have an active component that will allow us to be less invasive and allow us to achieve things that we can't today. What if I, on demand, could increase the width of the biologic width? I mean, increase the amount of biologic width. I could grow papillas without changing bone level. Well, I'll end my presentation by giving you a brief overview of a study that we published in Journal of Periodontology this year in 2007, and this is the first randomized controlled clinical trial ever done on augmentation of the papilla, and we used a novel approach using the patient's own fibroblasts. The fibroblasts are extracted from a little biopsy. They are sent to a laboratory. In the laboratory, these fibroblasts, a cell line is made. They're grown out to about 200 million cells per ml. They're placed in an injectable medium, and we then take them to the papilla and we inject the fibroblasts into the papilla, expanding the papilla. Now, we're not injecting a collagen, we're not injecting a filler, we're injecting living cells. Think of it as a dynamic protein delivery device that's not only going to maintain that over time, but perhaps continue to help plump it out. Now, we know a little bit about the structure and the vascularity of the papilla, but we're just really now learning a lot about gingival fibroblasts. I mean, I used to think of them as very boring cells, set around produce collagen, and that's about it. But if you look at the cytokine expression from gingival fibroblasts, they produce all sorts of things, and some of them that they produce we've already identified as being important in regeneration in periodontology. They're important for cell proliferation, extracellular matrix production, growth factor production, cytokine production, and they have a great deal of phenotypic heterogeneity. In other words, you can get more undifferentiated mesenchymal cells from gingival tissue than you can any other tissue in the body. And if you can take those cells and direct them in the right way, theoretically, you could actually get regeneration from these fibroblasts. So in our study, we had 20 patients, total 118 sites. 40 of those were matched, randomized, and test control. Primary endpoint was a change in the baseline from the papilla to the contact point. And we measured it with a probe, with a caliper, and with digital analysis of our photographs. We also had secondary endpoints where we looked from the base of the contact to the alveolar crest, and we looked radiographically at the bone. So here at baseline, we're going to take our biopsy, we'll send it in, and have a cell line made before the cell line is sent, or before it's sent back to us. These cells can be immortalized, and so that you can come back and use them again without taking another biopsy. And this is how it looks when it comes to our office. Again, you're not looking at collagen, you're looking at living cells here, but I would imagine everybody in the audience has injected anesthetic into papillas, and you know you can't get any in there, right? The tissue is too firmly bound down. What makes us think that we're going to be able to expand the papilla with this kind of technique? So we developed what we call the papilla priming procedure. It's just a controlled surgical insult that allows us to go in and cause swelling. It also gives us access to all of the components of the papilla, to the bone, to the periosteum, to the connective tissue. And so if you look and see what happens, here is the papilla priming. At 3 days, you see it's swollen. At 7 days, it's beginning to mature, but it's still swollen. And at 21 days is all back to where it was. Well, let's think about what's going on a cellular level, because we use this concept as our experimental design. If you think about their wound repair, everybody agrees there's 3 phases of wound repair: inflammation, granulation tissue, and matrix formation and remodeling. And when you look at this, it looks very fixed and unyielding. But in nature, these different areas, inflammation, granulation tissue, they can last longer. Some domes don't last as long, and there could be considerable overlap. So let's think what happens as we go through this. When we start our papilla priming procedure, within seconds, plasma proteins, primarily fibrinogen, coat the wound surface and begin the process of wound repair. Within an hour, we enter the early component of the inflammatory phase, and neutrophils begin to come into this area, and within 12 hours, we see swelling above baseline as the body begins to upregulate the production of fibroblasts, because the body's trying to heal itself, so it's regulating its own fibroblasts. These fibroblasts are producing collagen. By 3 days, we enter the late component of the inflammatory phase. The neutrophils are replaced by macrophages. You see that you still have swelling, but it's looking more mature. These macrophages are producing growth factors that are supporting angiogenesis, fibroblast production, and collagen accumulation. And as we move into around 5 days, we enter the granulation tissue formation phase. And at around 5 to 7 days, the body begins to shut down the natural production of fibroblasts. And collagen accumulation then begins to diminish, and you start getting into wound contraction. Most people agree that it's the length of the granulation tissue formation phase that'll dictate how much tissue you have at the end of a wound. For example, if you have a very short granulation tissue formation phase, there's not a long enough time to produce fibroblast, collagen, and all those other things to create tissue, so you could end up with a net loss. If theoretically, if we could increase the length of the granulation tissue formation phase, though, we could end up having a net gain, and that's what we tried to do in our study. So here we're coming in, we're injecting fibroblasts into the papilla. You can see as I do this how the papilla begins to blanch, but also look when we're doing our injection. We're doing our injection about 5 to 7 days after the papilla priming. Why is that? Well, it's because the body is shutting down its own production of fibroblasts at that point, so we want to go in and jumpstart it again, hit it with some more fibroblasts. And you can see it blanching here. We're able on average to inject somewhere between 6 to 8 million fibroblasts, and we dose that 3 different times at 7-day intervals, trying to get the most of the fibroblasts as we can into that area. This was taken off of one of the dermatologic papers using this material, and you can see that at 6 months you have more fibroblasts, a thicker dermis, no signs of inflammation. What happens is after the fibroblasts are injected, they take their spot in the normal dermal architecture, begin to produce collagen, and stimulate native cells to do the same thing. So that's our experimental concept, that we went in and strategically injected fibroblasts to keep this granulation tissue formation phase going in an effort to rebuild the papilla. Now, what we found in our conclusion, we had our patients were blinded to the placebo and the cells, and we had a blinded examiner, and we found that both with the blinded examiner and the patient that we found statistically significant improvement over the papilla in papilla height. In other words, our patients thought this was working, and our blinded investigator thought this was working. And since this is a procedure that we do because of patient desire, that is a very important finding. But the problem that we had was that our objective measurements didn't correlate with our visual analog scale. One reason that could have been is because we weren't measuring volume of tissue, we were only measuring height. And one of the things that perhaps the patient and the blinded examiner were seeing that they found more pleasing was the fact that we have plumper papilla, as you can see here, and we weren't capturing that. So that may be one of the reasons. But certainly our measurement techniques were problematic from the very beginning. You're dealing with papillas that are spaces that are in the 2 and 3 millimeter range, and if you're using a standard perio probe with a standard of error of about 1 millimeter, you would get a 50% improvement or decline in result and not even be able to measure it. When we were using our digital caliper off of our models, by virtue that you have open interproximal spaces, when you take that impression out, it's going to tear. That introduces variables. Our best and most sensitive was using digital analysis from our photographs. We standardized all of our photographs as far as magnification, but they weren't all standardized as far as angulation, and they went in mathematically and corrected that on the XYZ axis, but still there's some error. We also found that papillas don't always look like we were taught they would look like. We're taught papillas look like this, right? Lots of papillas look like this. Many papillas are concave, not convex. None of these have been treated. So the way that we think papillas, the way we typically think they don't always look like that. In fact, most don't. I'll share with you just a couple of the patients as far as the results here. On all of these panels, this will be day 0, 4 months, papilla priming, first injection, second injection, third injection, 2 months after and 3 and 4 months after the first injection. And it's easier to look here on, if you look at the timeline here. This is papilla priming, first injection, second injection. Look how much growth we have in the papilla from the second injection to the third. No more cells are put in there, but these fibroblasts are sitting there generating the connective tissue, and it's closing the papilla. Then this is third injection, 2 months, 3 months, 4 months, maintaining pretty much out. Another patient, papilla priming, first injection, second injection, third injection. Okay, no more injections are given, but look how the papilla closes down, how the open interproximal space closes down as the papilla grows. Again, the fibroblasts are producing the collagen, closing the papilla, even though no more injections have been given. Another case, papilla priming, first injection, second injection, third injection, again, completely closes, then we get a little rebound. So our conclusions from this study were autologous fibroblasts are safe and may be efficacious for treatment of open interproximal spaces. Investigator and subjects to VAS assessment of test sites were superior to placebo, but our objective endpoints failed to demonstrate statistical significance. Further studies are needed with more appropriate power and sensitive measurement techniques. We are now doing a study with more sensitive measurement techniques, allowing us to have very standardized photographs, controlling for all the angulations, and we're looking also at dosing in this, at what time should we be dosing. One of the things we found in the first study was that on the whole, people did very well up to about 2 months. And then we started getting some variability, so we're looking at dosing schedule as well, and if things go well, we hope that one day we'll be able to get into a multi-center trial and be able to, now that we know it's possible, find out how we can make it more predictable. An interesting article at least caught my eye in this year's Journal of Periodontology. A group out of Canada showed that fibroblasts from papilla act different than fibroblasts from the just gingival marginal tissue. And as I read that, it made sense to me as a clinician, because if you have a patient that's on immunosuppressive drugs, or you have a patient on Dilantin, where do you see the growth first? It's always in the papilla, isn't it? So I'm thinking that if we do further studies, we don't want to take our biopsies from the palate like I did. Let's take our biopsy from a papilla itself, someplace outside the aesthetic zone. But of course, we know from the guidelines I just told you, if you've got the bone, the papilla is going to grow back, right? So we're not doing anything wrong. That may also be a real key as we move into this area. I'm going to end by wanting you to focus in on this panel. Again, in today's world of computers, you can do anything you want with computers, but this is not computer altered. You're just going to look at a time lapse from day 0 to 4 months, and so focus here. Now that we know that it's possible, if we can make it predictable, I'll be opening papilla parlors next to every bright smile across the United States. Certainly, our grafting instruments in the future may be very different than our grafting instruments in the past. It is about the smile, and I'll leave you with one of my favorite quotes. A smile costs nothing but gives so much. It enriches those who receive without making poorer those who give. It takes but a moment, but the memory of it sometimes lasts forever. None is so rich or mighty that he cannot get along without it, and none is so poor that he cannot be made rich by it. A smile creates happiness in the home, fosters goodwill in business, and is the countersign of friendship. It brings rest to the weary, cheer to the discouraged, sunshine to the sad, and is nature's best antidote for trouble. Yet it cannot be bought, begged, borrowed, or stolen, for it's something that has no value to anyone until it's given away. Some people are too tired to give you a smile. Give them one of yours, as none needs a smile so much as he who has no more to give. It is revolutionary what we can do today, and it will be even more so in the future. All of these kind of procedures, especially as we move into biosurgery, surgery with active components, should provide for all of us an increased scope of practice, but more importantly, provide for our patients treatment that's less invasive and more predictable. Thank you very much.